propensity of getting ITP, because when your platelet counts go up, those cells go down. So it's a possibility.
Thank you, John. We'll move on to the next presentation. The association supported a pilot study of ITP in pregnancy some while back, and that was sufficiently successful. It was presented at this meeting 3 or 4 years ago that we decided to develop a registry, which has been overseen by Guys. And as Vickie said earlier, Sue Robinson is looking after that. It's not able to be here today, and I'm very pleased that Vickie, who was very heavily involved with the adult registry until she moved to Guys, is going to present that data and also talk about ITP and pregnancy in general. Vickie.
Thank you, Adrian, and thanks to Adrian and Mervyn, both for their unwavering support of these projects and for inviting myself to come and speak. So a slightly different pace of talk, hopefully, but also a very different angle now. You've heard about the complex immunology behind ITP and the potential vast array of treatments, but actually for ITP in pregnancy, we don't quite have those number of options, and we'll talk through that in a little bit more detail. So I was going to kind of touch on low platelets in pregnancy, the complications of ITP in pregnancy, its treatment, and then a kind of update we've almost reached 100 patients in the pregnancy registry, which for a rare disease and then a rare event within a rare disease is actually pretty impressive and will be the largest data set, certainly that has been published in the UK and probably internationally. So just I don't think you've seen any huge numbers of pictures of platelets and other bits in these sessions so far, but as John said, platelets are made in the bone marrow and they come from megakaryocytes, mega being big and karyocyte cell. And the platelets themselves actually don't have nuclei. They're fragments of the cytoplasm of a megakaryocyte, which has lots of nuclei and is very, very active. They have a very short lifespan. And their function really is to provide a surface for clotting factors. And as John said, they're also probably likely part of the kind of early defense immune system that bridges the space between infection and coagulation. And when they're activated, they circulate as kind of little fragments of cytoplasm, but when they're activated, they put out pseudopodia and ultimately change shape, which means that they have a much bigger service for coagulation and can get into little spaces where there might be vessel injury or otherwise. We have way more platelets than we actually need for hemostasis, and the normal platelet count is 150 to 400, but you will hear and you will know that actually bleeding-wise, we don't see significant bleeding until the platelet count is way below this. And the two bulk causes of a low platelet count are either you don't make enough platelets because your bone marrow isn't working very well, there's something else in the marrow, you've not given it enough building blocks, B12 folate, or they are destroyed more rapidly. And that can either be immune, like John's described, where the body is suddenly seeing your platelets as foreign and the tolerance is gone, or it can be non-immune for various other reasons. So a low platelet count is actually the second most common hematological abnormality in pregnancy. This histogram here, the pink is control, so this is non-pregnant, and the white is pregnant. And you can see there is a shift over. So the highest number of patients with a platelet count is shifted over to the left in pregnancy. So the average platelet count is lower in pregnancy normally. And we see it in about 5 to 10% of women who have a platelet count below what we would consider an acceptable threshold. And platelets in women generally in pregnancy do show a downward trajectory from the second trimester, and there are various reasons for that. It's more common in twin and triplet pregnancies, and ITP of those is the most common cause of a platelet count below 50 in the first and second trimester. But actually, if you've not had ITP before and you suddenly develop a lower platelet count during the second and third trimester of pregnancy, other things come into play. So ITP isn't necessarily the most common. And there are lots of causes of a low platelet count in pregnancy. Some of them are very specific to pregnancy. So gestational thrombocytopenia basically means a low platelet count in pregnancy for which there's no other cause and it's not ITP. But they don't tend to get severely low platelet counts. They don't respond to steroids and IVIG, and not much needs to be done. The platelet count generally isn't below 80. There are some hypertensive syndromes, so preeclampsia and the associated conditions. Some women can get very activated clotting within the circulation in pregnancy when they're unwell, which then means the platelet count drops. And then we've got lots of other conditions that happen outside of pregnancy, but that can either unmask themselves during pregnancy or become a problem during pregnancy, of which ITP is one. So because there's a large number of causes of low platelet count in pregnancy, when you see your consultant, there's going to be a lot of things going through their mind and their sieve as they try and work out what investigations to do, in which sequence to get to the diagnosis of ITP. And you have heard before that ITP fundamentally is a diagnosis of exclusion. So we have to have excluded all these other unusual syndromes before we can get to ITP, including viral infections, but I won't expect you to learn all that. But the first thing, as Drew said in his talk earlier, is the platelet count low? Because there are patients who come to clinic, please see this patient with a low platelet count, pregnancy or otherwise, we think they might have ITP and they don't. They have a completely normal and functioning bone marrow. In fact, they're making a completely normal number of platelets. But what happens when we put their blood into the little purple top tube that's got EDTA in it is the EDTA makes the platelets stick together, and that's a platelet clump in the peripheral blood. So that's the first thing we need to do. Is it genuinely low, or is this an artificial lab phenomenon? We would then work through all of our investigations, and if we come to a diagnosis, likely diagnosis of ITP in pregnancy, then our brain is going into, okay, so we need to manage the pregnant lady, and we also need to minimize any complications to the baby, and get this lady through pregnancy in a shared partnership so that ultimately a healthy baby comes out at the other end. And the main complications of ITP in pregnancy are bleeding, because the platelet count is low, thrombosis. Those that were in the women's session with me earlier, we talked a little bit about thrombosis and ITP. Some of the conditions that are associated with ITP, like antiphospholipid syndrome, can affect the growth of the baby. We need to try and avoid any bleeding after the baby is delivered. Again, we talked a little bit about this in the women's session earlier, about sometimes the antibodies can cross the placenta and the baby can have a low platelet count for a short period of time. And we want to also avoid any treatment-related side effects. And we've heard certainly from several of the groups and the talks how some of our treatments can make patients feel unwell. So this is the international consensus guideline that Drew and others wrote, and a platelet count of 20 to 30 in a non-bleeding patient is safe for most of pregnancy. So if the platelet count is not below 20 and you are not bleeding, as a broad rule of thumb, we try and avoid over-treating pregnant women, and we try and avoid the side effects of some of the treatments. By the time we hit delivery, we would like a platelet count of 50 for vaginal and cesarean section. And if the lady would like regional or epidural anaesthesia, then we're looking more to a platelet count of 70. Now, if I was doing this talk to haematologists and obstetricians, I could probably have about 10 slides on epidural anaesthesia and platelet count thresholds, because there is a lot of discussion. And if any of you have had epidurals at a lower platelet count than that, that is not necessarily wrong, because there are some very experienced obstetric anaesthetists who can successfully do epidural and regional anaesthesia right down to a platelet count of 50. But there's a little bit of that is UK specific, and there's definitely some of that is site specific. And so for a kind of general safety, we would say platelet counts of 70. And our initial treatment is usually oral steroids and IVIG. So steroids in pregnancy, the advantages are that they act pretty rapidly. I say they're safe. They've been around a long time. We understand them. Okay, I'm not saying they're without side effects, and we'll talk about those in a minute, but we understand what they do. And we can titrate the dose. So we have some degree of control over being able to increase or reduce the dose to get to the platelet count of what we want without over-treating the woman. But there are some disadvantages. Steroids for any condition in pregnancy can affect the blood sugar, and we can tip pregnant women from a pre-diabetic into a diabetic state, so that needs to be monitored. They can exacerbate hypertension and project pregnancy-induced hypertension, so we have to watch that quite closely. I think even outside of pregnancy, they can cause insomnia, and that can certainly be made worse in pregnancy. And some of the schedules of steroids, particularly the very high doses of dexamethasone, can affect the baby's growth. So we have to be a little bit careful, but they do have some advantages. We know how they work. And generally, to avoid many of these, we use a low dose of prednisone. We use much lower doses than we do in non-pregnant patients with ITP. So we'd be thinking kind of 20, 30, maybe absolute max for a very short period, 40, but generally much lower doses of steroids. So our other option acutely is intravenous immunoglobulin. There are many, the advantage that it is rapid acting, and certainly if a woman comes in bleeding, we would be thinking IVIG. It's intermittent dosing, so that patients don't need to think about taking tablets all the time, but it's fairly frequent intermittent dosing, because those of you who had IVIG know it doesn't last forever. We get quite high response rates, and safe for the fetus aren't many issues. And this is my little picture of autoantibodies against something, and we don't really know how IVIG works, but probably kind of mops up and avoids some of the destruction by blocking some of the cellular receptors. But headaches can be a significant problem in IVIG. Nikki talked earlier, didn't she, about it being much worse in teenagers. Women already get headaches, might have a bit of high blood pressure, and then we give them something that makes it worse. Patients need to be in hospital to take it. It's not something they can have at home, so they are going to have to come into a day unit setting. And if they're getting lots of headaches, it's going to be given quite slowly, so that can be quite cumbersome. These poor ladies are trying to manage work and maybe other children at home and everything else, so we've got to be mindful of that wider impact. They can cause allergic reactions, and they are prothrombotic. So we do need to then look at the wider picture of the patient and say, well, are there other thrombotic risk factors? Is this safe? Do we need to give it slowly? Do we need to give a slightly different dose? To try and minimise some of those implications. And if steroids or IVIG fail or aren't well tolerated, we have other options, but not as many options as we might have outside of the pregnancy setting. As far as the medicines that kind of control the immune system, azathioprine is probably the most commonly used in pregnancy. It's safe and well tolerated. The bulk of our data comes from lupus and renal transplantation patients, actually, but there's no evidence there's any harm, and it can be very effective in ITP, but it takes 6 weeks to work, at least. So there is quite a bit of lag time while you start at a low dose, kind of work your dose up, and then see whether there's any effect. So steroids and IVIG may be needed to be used. This is not a quick solution, but it can allow the steroid dose and mean that you don't need to take IVIG. You do need to have an enzyme to be able to metabolize it. So we have to do some tests before. Not everybody can tolerate azathioprine. Rituximab, which is the medicine that lowers the number of B cells and therefore is thought to lower the number of antibodies against the platelets, is well tolerated with response rates of about 50%. There has been anxiety about giving rituximab in pregnancy, certainly not licensed in pregnancy. Our practice generally would be if a lady is on treatment for ITP that is not suitable for pregnancy, we would probably have a discussion about starting rituximab beforehand to give some stability going in. But it has been given during pregnancy in reasonably large numbers of women now. And the main consequence is a low baby lymphocyte count. This doesn't seem to affect the baby long term. And by about 6 months, that lymphocyte count has come back. But I think there are implications to think about then whether the baby will respond to vaccination and other. Hydroxychloroquine is something that's often used for lupus antiphospholipids patients, but can be quite effective in just bringing up, it doesn't necessarily normalise the platelet count, but can bring it to a level where you don't need as many steroids. I will come on to TPO-RAs in a minute, and this came up interestingly in our women's discussion earlier about TPO-RAs in pregnancy. One lady had a TPO-RA in pregnancy, and someone went, what? I didn't think they were allowed. So we will talk a little bit, and I'm hopefully have a slide on that to just look at the data that we pulled together. Splenectomies, we don't do very many in the UK. If we felt that somebody did need their spleen taking out because no other options were effective and working, and we really needed a good platelet count for delivery, it's only really done in the second trimester, but not all patients respond. And certainly outside of pregnancy, we will be doing an Indium label platelet scan now to see where the bulk of the platelet destruction takes place, because if the bulk of the destruction isn't in the spleen, there's limited benefit to taking the spleen out, and there are some longer term consequences to having a splenectomy in a small number of patients. But we can't use some of the agents that we use either for routine management of ITP or the kind of acute setting where the platelet count drops and the patient's bleeding, because they can harm the baby. So thrombopoietin receptor agonists, L-Trompag, romiplostim, and now avatrombopag are not licensed for the use in pregnancy. There have been no trials. But increasing case studies have shown kind of good responses and a safety profile. And this is from the French group, from Marc Michel, who's a big expert in Paris in ITP. And they pulled together the patients who had a thrombopoietin receptor agonist during pregnancy, where all the other options had been exhausted. And they had 15 women who had had at least a week TPO-RA, 8L trauma pag, which is the tablet, 7 on romiplostim, which is the injection, and it was 17 pregnancies, 18 neonates. And then actually patients weren't on the TPO-RAs for very long. So these are generally being used to just get that platelet count up for delivery. And we're not really using them in the first and second trimester. Some mothers had headaches, but there were no thromboembolic events, no fetal losses, and one slightly high platelet count. Thrombocytosis is the other way. That's a slightly high platelet count in the neonate. And one baby had died, but from something completely unrelated to that ITP or treatment. And the overall response rate was very good, 77%, given that they'd got to this stage because steroids and IVIG and azathioprine weren't helpful, but mostly in combination with something else. So it was being added on to, and those single agents hadn't been successful on their own. So whilst they're not licensed and there are no big trials, if you fall pregnant, have baby, other half has a baby, this may be discussed with you as a way to get the platelet count up just for delivery so that we hit those right thresholds and then you can stop afterwards. So how do we manage delivery? We don't generally need to go in and try and measure the baby's platelet count in utero, the fetus's platelet count in utero. And we very much encourage that the choice of delivery is based on obstetric considerations. And it may be that the choice is a cesarean section because they've got hypertension, big baby, but from an ITP point of view, the risk of the baby bleeding and neonate bleeding into the head is very low. And there's no evidence that this is reduced by cesarean section particularly. I've put this on here because this is what some of the guidelines say, avoiding fetal scalp electrodes, which is where during delivery they put a little needle in to try and see how the baby's doing, fetal blood sampling, ventouse where they put the sucker to pull out, or rotational forceps where they put the forceps in to pull out. I think increasingly this is probably not an absolute hard and fast rule. But I think the guidelines currently still say this, although in practice, there is some variability now across units without any evidence of any challenges. We must do a core platelet count because the neonate can have a low count. And because of this, you know, particularly if you made the platelet count pretty good in delivery, and for the vast majority of ladies with ITP, they can go through pregnancy without too many problems. It is not the vast majority that run into problems. We do need to think about avoiding blood clots afterwards because the postpartum period in any woman is the highest risk for thrombosis just after delivery. So the neonatal care, the platelet count is less than 50 in about 5 to 20% of cases, and I'll show you what the data from our registry shows. Severe thrombocytopenia major bleeding is uncommon. The thrombocytopenia doesn't correlate with the severity of the maternal ITP. There is a little bit of literature that shows if you had ITP before pregnancy rather than developing it in pregnancy, perhaps there's a slightly increased risk. If you have one baby affected with a low platelet count, it is more likely you will have others. That probably is about the strongest risk factor we have. But if this is your first baby, we have no way of knowing. The big one that we really kind of drum home to obstetricians and haematologists that perhaps aren't in the bigger ITP centres is that if the mum has had a splenectomy and now has a normal platelet count, that is a risk factor for a low platelet count in the baby. So just assuming that if the mum's platelet count is normal, everything's fine, and the ITP is completely quiescent and therefore the baby will be fine, isn't right if the mum's had a splenectomy. And again, I will show you our data. So moving on to the registry data, we've consented 95 patients now, which is pretty good going for a rare disease. The registry's been going since about towards the end of 2018, and we've got data for 91 patients entered on, and 84 women have delivered. And it's a predominance of patients who were diagnosed with ITP before pregnancy, 24% in, and we're still chasing some data for absolute clarification of the other 10. This is the average age, so probably not much different from the UK generally. And about 50% of women have at least one bleeding event during pregnancy. Most have not many bleeding events, but there are a few patients in there who obviously had quite a challenging time with significant frequent bleeding events during pregnancy. We had a quick look at the average age of the patients at delivery to see if maybe age was associated with that, either one way or the other, and it doesn't appear to be. And the most of the bleeding events are either bruises, petechiae, mucosal, which is predominantly nosebleeds, and actually pregnant women, even without ITP, have an increased rate of nosebleeds because of the increased blood flow and circulating volume. So that probably isn't a surprise. The organ bleeding predominantly was vaginal bleeding, and then other sites haven't specified. And about 50% of women are recorded as needing treatment during pregnancy. And as we would expect, given we know about what's safe and appropriate, steroids and IVIG are the most common, followed by azathioprine. But we have got patients now coming through who have had L-tromopag and romiplostim. And I think you will see romiplostim is more commonly used than L-tromopag in pregnancy. Certainly that would be our practice. And as women run through pregnancy, it's more likely they're going to get a treatment. And that is, as the guidelines would suggest, and supportive of the guideline data, that actually we try and leave women alone unless they're running into problems if the platelet count's 20 to 30 until they hit that delivery period when we need 50 or 70, depending on the choice of pain relief. About 50% of women are delivering vaginally, 50% are delivering by caesarean section, and the reason for caesarean section is listed under here. So this would be considered probably more elective, kind of a maternal comorbidity, which might include ITP and may or may not be a good reason for a caesarean. As you know, obstetricians much prefer vaginal delivery. Women get over it much better. There are fewer complications. They're mobile more quickly. So where possible, the encouragement is for a vaginal delivery. These ones are previous caesarean or uterine surgery, where therefore vaginal delivery wasn't felt to be appropriate, failure to progress in the first stage of pregnancy, failure to progress in the second stage, and fetal distress. So these would be emergency indications for caesarean. We can't control those. It is what it is. And then patient choice and unknown still being chased. And if you compare that to national data of how women deliver nationally, about 30% deliver by caesarean section and about 70% for vaginal delivery. So certainly there are more as a percentage, more women are having a caesarean section. And it will be interesting to try and unpick in more detail in that data what those reasons are. And it may be entirely appropriate. It may be a consequence of some of the treatments, but it may be a little bit that some people in non-big units where there isn't that wider MDT are more nervous and feel that they have more control in a caesarean setting of a caesarean section. So neonatal platelet counts, this is all neonates. It's a vast majority, the platelet counts are fine. Over 100 is certainly fine. 50 to 100, we'd monitor again, but probably don't need to intervene. And these lower platelet counts, we might need to give the baby some treatment. But the vast majority, actually, the platelet counts are fine. And what is helpful about the registry is we're also collecting data about breastfeeding and some sequential work. So I think that will be helpful then, because often our mums do say, should I breastfeed if the platelet count's low? Am I going to make it worse? And there's limited literature currently in cohorts with large numbers of patients to be able to inform that. But look at this, as we talked about earlier, babies born to mothers who had a prior splenectomy, we've got a couple where it's not recorded and they're all low. So, and the mum's platelet counts were not. So that is we would reinforce that point to our clinicians. It's not so much for the patients to remember, but I think this starts to back up what we are seeing, that there are some caveats where we have to be a little bit careful. And these are then the patients where you'd say, right, we just need to be very careful of that baby during delivery. We probably do want to avoid scalp electrodes and everything else. But actually, if the vast majority of platelet counts are okay, do we want to tie the obstetrician's hands and say, you can't do this and you can't do that, just in case, when most of the time the patients are okay? And there are some things that they can do that are lower bleed risk for intracranial hemorrhage. So hopefully I've slightly caught up a bit of time, and this is really just to thank, this is an enormous amount of work. We are very grateful to Mervyn and the Support Association for supporting this, and being so positive about how we collect this data and move forward for learning. And Fred's going to present the adult work, and it's a similar thing. These are our PI sites, and this is the kind of team that it takes to be able to, we have to run it, the governance, the steering committee, the ethics, the validity of the projects we're doing, the scrutiny, the people coming back going, are you sure? It's quite a piece of work, and does involve funding also from some of our commercial as well as charitable partners, including the NIHR and the ITP Support Association. So I will stop there. We've covered quite a lot, and happy to take any questions if I have time-ish. Maybe one or two.
I think we've got time for a couple of questions. There's a couple of hands up there. There used to be a suggestion that IVIG protected the neonate from developing thrombocytopenia. Do you have any data from this registry to be able to
So
see?
we may do, we haven't looked specifically at that question yet. I think one of the challenges is you need enough numbers of patients, as Adrian will, I mean, I'm telling Adrian, he knows that. One of the challenges that you need to have enough patients to be able to be sure that your conclusions are robust and applicable across the group. So we will look, but I don't know that we've got enough
Yeah.
on the low platelet side yet to be able to say, was there a significant difference? But I think this is quite valuable data to optimize what we can put in clinically to optimize outcomes and either avoid over interventions or under interventions, and that personalized management that we were talking about, particularly where we can't use the full array of agents we might want to.
The question, whichever.
Right.
My platelets went down to 0 during pregnancy. And then when my son was born, his platelets were 9. And he had treatment for 30. So what you mentioned about you mentioned some connection between breastfeeding and
No, well, no. So we don't know. We don't know whether carrying on. Yes. So the question is, somebody had low platelet counts in pregnancy. The baby had a low platelet count. We don't know whether breastfeeding makes it worse, better, the same. Doesn't matter exactly. Some of the treatments you can't give in breastfeeding. I'm hoping that some of this will help us as we unpick some of those answers. Some say absolutely, it definitely makes it worse. We've certainly had women who breastfeed in pregnancy and the baby's been fine without low platelet count. So I think we can't say hard and fast. There just aren't, unless Cindy, you're aware that I'm not aware of any massive studies that have really looked at it. And it's not a clear cut.
No, I spent 2.5.
Yeah. I mean, many can, but there are some who won't breastfeed on those grounds. Yeah.
Sorry.
There are some mums who won't breastfeed just in case. Yeah.
Okay.
Dr. Austin, you're going to have to shout so everyone can hear it back.
I'm cognizant this is a patient meeting, so I don't want to take a ask you, but one very quick one. I just know that recently it's been on my mind, and that is about monitoring the neonates who's had thrombocytopenia developed. It's 5 to 25% neonates from mums with ITP. It seems to be a whole array of ways to do that, and certainly in the UK, patients are sent home very quickly. The new mums and the babies go to bed, and I see that some people say, "Oh, I'll just measure it once on the cord blood," and then it's almost, "No, I always do it on day 3." Oh, no, really need to do it on day 5. I was just wondering, you've got some excellent data there. I'm wondering whether we have.
Yeah. So
on that.
if the neonatal count is completely normal at pregnancy, I have to say we don't